Good afternoon, ladies and gentlemen. We are going to talk about the topic of veins today. Know that the venous system serves for return of the blood back to the heart. The differences between the arterial and venous system is, of course, the level of oxygen. But there are some other differences. First is that there is a low blood pressure within the venous circulation, and it's from 25 millimeters of mercury or torrs to 0. And even there can be a negative pressure, especially in the right atrium and in the head and neck veins. And it serves also as a blood reservoir, so there is 70 to 80% of blood within the veins. And it's because the wall of the veins is thinner, so they can be more enlarged. We distinguish postcapillary venules, then a smaller, middle, and large caliber veins. That's just a general classification. As you can see here on the histological slide, the difference between the artery and vein as for the histology is that the main part of the wall is the external or adventitial layer, this tunica, which is not only fibrous, but mainly from smooth muscle cells. And on the contrary, the middle layer, tunica media, is quite thinner. So we start with venules, and the caliber of venules is from 200 micrometers to 1 millimeter approximately. Yeah, and the wall is similar, so very thin media and thick adventitia. And if you look at this histological slide, you can see that the wall of venule is thinner than the wall of the arteriole. As for small and middle caliber veins, there is the same arrangement. So adventitia is the largest one. And what we can find within these veins are valvules. As you can see on the figure down, the valvules are typically from two cusps or two valvules. So one valve is formed by two valvules. So it is quite similar to the semilunar valves, but they are composed of three and these of only two. We can describe there a free margin and the affixed margin. We can describe the sinus, which is the space inside, here with the arrow, this space inside. And we can describe the commissure, which is between these two valvules. And they serve for one-way circulation of the blood. We have parts of the body where there are no valves. Generally, we can find valves within the skin, subcutaneous tissue, and then in limbs. Yeah? If the valves do not work properly, then the blood can reverse the flow, and there can be enlargement, which are called varices. These valves are of the similar histological structure as in the heart, so they are duplications of intima. And when we look at the large caliber veins, again, what we can see that adventitia is the largest layer, and as for the smooth muscle cells, they are arranged in spirals. These spirals are more longitudinal than circular. The angle is between 10 and 25 degrees, which is not so much important, but they are not, as you can read, really precisely longitudinal. They are more spiral. And in the wall, we can find even vasa vasorum, so the proper vessels which supply the adventitia and external 2/3 of the media of the venous wall. So that's just generally the structure. And now how they are arranged. We have two independent systems which drain separately into the heart. And that's the system of superior vena cava, which drains the head, neck, upper limbs, and thorax. And inferior vena cava, which drains the abdomen, pelvis, and lower limbs. And then we have a system of portal vein, which drains the unpaired abdominal organs, which means all the organs of the digestive tube, plus its glands, liver, pancreas, and don't forget spleen. And it drains then into the terminal segment of the inferior vena cava. And these three systems possess mutual anastomosis. Yeah? And this anastomosis allows the different blood flow in case of closure of one of these veins. So there can be thrombosis or compression of the superior inferior caval vein, or of the portal vein, or impairment of the circulation within liver, mainly due to cirrhosis. And then these anastomosis, which are pre-existing, they enlarge and they start to connect these systems. So we can have either portocaval between the portal vein and superior or inferior vena cava, or cavocaval or cavocaval between the superior and inferior caval vein. We will talk about them just at the end. Another arrangement is superficial and deep. So we have two layers in limbs, and then mainly in the neck, where we find the superficial veins. You know them, cephalic, basilic, and great and lesser saphenous. But in the neck, we have the anterior and external jugular as well. Yeah. Then we have the deep systems, and in limbs between these two systems, we have perforators. These perforators are not in the neck, but we can find them in the upper and lower limb. So we can start with the superior vena cava. So here is the superior vena cava drawing. And now we can highlight the main information. So the superior vena cava is located on the right side, as the inferior vena cava. It's because we have left-sided aorta, we have right-sided caval veins. But of course, based on impairment of development, we can have left-sided caval vein, either superior or inferior or both. Superior vena cava is quite short, and it originates from two brachiocephalic veins. So if I draw it separately somewhere here, so we have superior vena cava, and it originates from brachiocephalic vein. Yeah? So right and left brachiocephalic vein. And you can see that the right one is straight and it's perpendicular. The left one is oblique. It's longer. Azygos vein, which is a vein draining, and you can see it here, this one, is draining the thorax. Then it runs behind and above pulmonary hilum. It also causes a groove on the right lung, and it drains into superior vena cava. Sorry, back to this color. Brachiocephalic vein originates from a vein of the upper limb, subclavian, and from vein of the head, internal jugular, on both sides, of course. And then some tributaries in this area. We have tributary which comes from thyroid gland. The thyroid gland forms inferior thyroid arteries, and they merge into so-called unpaired thyroid plexus. In Latin, plexus thyroideus impar. And it drains into the left brachiocephalic vein. And we know that this can hinder the inferior tracheostomy, as we find it in front of trachea. Okay, then there can be another veins draining here, and that's the vertebral. Yeah, I use a different color. So this is a vertebral vein. We know that vertebral artery is branched from subclavian, but the vertebral vein drains as far as the brachiocephalic on both sides. Yeah, so also here we have the vertebral. Then from below we have internal thoracic. Yeah, so here we have internal thoracic, right and left. The internal thoracic on the right side can drain either here into brachiocephalic, or it can even drain a bit caudally into the superior vena cava. Yeah, it depends. So it can drain even here. And then we have here veins from intercostal spaces. Yeah, we can see it here, these, which drain the intercostal spaces. So the azygos vein receives a vein which is called superior intercostal, and it drains the superior intercostal spaces. And then, of course, we have here the posterior intercostal separately. Yeah, and then there can be some smaller mediastinal visceral tributaries. So, do you have question to that? So here we have all the veins which drain there. I forget to talk about the supreme intercostal, but we come to this then later in azygos system again. Yeah. So as for the development, the superior vena cava comes from the precardinal vein. Yeah, and as I said, it's on the right side. It comes from the right precardinal vein. The left one fades out, and it remains only as a very, very small vein of left atrium, so-called Marshall's vein, which produces a small fold of a pericardium. Yeah, but it's nothing important. So clinically, the superior vena cava, as it's a vein with thin wall, it can be compressed from outside. Yeah? And you can see that it can be compressed here by tumor or here by aneurysm of ascending aorta. You can see that this is not normal. Yeah? You can see the descending aorta and its caliber, and the ascending aorta is 3 times larger. So this is aneurysm compressing the superior vena cava. Or the blood flow can be blocked internally by thrombus, which we can see here. Yeah. So what then happens? Then the blood is stuck here, and the cavo-caval anastomosis have to open. So you can see in the figure that we have here cavo-caval anastomosis on the lateral side of the trunk, and here we have the enlarged azygos vein. Yeah, we will talk about this anastomosis later. But you can see how the patient then looks like on this figure on the left side. That there's a stasis of the blood. The patient is a bit violet, and we can see the venous stars on under the skin. Yeah, so that's the syndrome of superior vena cava, either blocked outside by tumor or aneurysm, or inside by thrombus. Okay, then when we continue to the heads, internal jugular vein, we come first to this. Here we can see again a superior vena cava and right and left brachiocephalic trunk, and then this. Internal jugular vein and subclavian vein. As they meet, we call this angle venous angle. Venous angle is this. And what drains into the venous angle? Into the venous angle drains on the right side the lymphatic duct, and on the left side the thoracic duct. Yeah, we know these two largest and most important lymph trunks, where all the lymph is drained by these two trunks into the venous system just in front of the heart, and it's in so-called venous angle. Yeah, so please remember that, venous angle, and a place where a right lymphatic duct and a thoracic duct drain. So back to internal jugular vein. Now we know where it terminates in venous angle. And where does it originate? It originates in jugular foramen. Yeah, we come to this in a minute. So the beginning and the end are enlarged, and they are enlarged, and the enlargement is called a bulb. And within the inferior bulb, we have usually a valve. That's the only valve in internal jugular vein, and it's within the inferior bulb. So origin and beginning, there are bulbs. As for the topography, it is, of course, covered by carotid sheath together with carotid artery and vagus nerve. And we know that carotid sheath is part of pretracheal layer of cervical fascia. And then the topography is similar to carotid artery. So we find it in homotracheal and carotid triangles. So here we can see the origin of the internal jugular artery. Yeah, we can see the jugular foramen, and its dorsolateral part contains the bulb, and the bulb is formed by two sinuses, and it's the sigmoid sinus, which is this dorsal one, and the inferior petrous sinus, which is this ventral one. Yeah, inferior petrous sinus. We know that the jugular foramen in its ventromedial part contains the 9th, 10th, and 11th cranial nerve and a posterior meningeal artery. So that's the origin. These are the easy part of internal jugular vein. And now, easy scheme shows you all the branching. So now let's go into the details of this easy scheme. And first, we review all the tributaries which we have into internal jugular vein. So first, we have the intracranial, yeah, which are inside the skull. So sinuses, yeah, we will talk about the sinuses in detail. So sinuses, which are between the skull and the dura mater. Of course, vein of brain, yeah, cerebral veins. Meningeal veins. It's easy, they are similar to meningeal arteries. Diploic veins, these we find within diploe. And diploe, we know, is a spongy bone in our cranial vault bones. Yeah? So these veins will be inside the spongy bone. Labyrinthine veins supply inner ear, yeah? Similar to, or they drain inner ear, so similar to arteries. Emissary veins, we know all these from skull, yeah, from the openings of skull as they interconnect intracranial and extracranial veins. And finally, two ophthalmic veins which drain orbit via the superior and inferior ophthalmic fissure. Yeah, that's the overview of the intracranial. And now just overview of the extracranial. Okay, thyroid and pharyngeal, similar to arteries. Yeah, lingual, facial, similar to arteries. Of course, we have occipital, posterior auricular. And then we have this one, retromandibular. And for retromandibular, you can remember it runs together with the external carotid artery and its terminal segment, yeah? So external carotid artery is accompanied by retromandibular vein. And then, of course, we have two superficial, external jugular, anterior jugular, yeah? So this is just the overview. And now, let's go to the detail. The veins are the most variable part of the human body. So we will talk about a textbook pattern, but you can find many different variations. Yeah? As for example, you can see here that this anterior jugular vein is very thick, and this anterior jugular vein is thin. Yeah, so you can see differences in that, and they are usually not mentioned in the book, so you have to be prepared for that. Okay, we will start with the sinuses, and I will draw you an easy scheme how to be oriented and how to learn it. Yeah. So first, why we call them sinuses? I think you know this, as these are veins which has been absorbed by the dura mater. So there is no more adventitia and externa itself. All these, both these layers are replaced by dura mater. So it's very, very firm. Yeah. If you have a vein, you cut the vein, you open the vein, it starts to collapse. Why does it collapse? Low blood pressure and thin wall. Yeah. These sinuses, especially superior sagittal sinus, the transection has a triangular shape and it does not collapse. Yeah. Is it clinically important that it does not collapse? Can you give me the answer for this question? When I open the sinus, yeah, by trauma or injury or iatrogenically during operation, is there any danger when it stays open? No idea.
Blood flows out.
Sorry?
Faster? That blood flows out faster?
Of course, there's a bleeding, but there can be air embolia. Yeah, air embolia because there's a negative pressure. So then the air can be sucked in and get into the heart. So if you have any bleeding, any venous bleeding in the head and neck, just cover it quickly, yeah, to prevent the air embolia. Okay, what is confluence sinum or confluence of sinuses? It's this area here behind where you can see that the sinuses all meet, yeah? And finally, the blood which comes here drains to the sides via the transverse sinus, yeah? So this is so-called confluence of sinuses, and we find it at the internal occipital protuberance. And Willis cords are parts of dura mater which bridges the lumen of the sinuses. Here you can see that we have some unpaired sinuses, yeah, 5 of them. And then here you can see that we have some paired, yeah? I don't know how many, at least 10 of them, yeah? And we will draw a scheme for that. Don't worry, Abby, you look disappointed. We go through each of them. Here you can see the cords of Willis, yeah, which bridges the superior sagittal sinus. And here is another very important spot. You may know that on the skull, on the cranial vault from internal aspect, we can see so-called foveolae granulares, yeah? So granular foveoles. So these are small pits which we can find in this area. And in these small pits, there are protrusions which we call arachnoid granulations of Pacchione. Yeah? It was an Italian, Pacchione, arachnoid granulations. And these granulations serves for absorption of cerebrospinal fluid. Yeah? So the cerebrospinal fluid is absorbed here. If we have an injury here, inflammation and a formation of a scar, then it can cause a reduced absorption of cerebrospinal fluid. And what is the cause of hypertension of cerebrospinal fluid? Do you have any idea what happens if you have still production but no absorption? Because it's a fluid, it is incompressible. So it compresses the brain tissue, and it's called a hydrocephalus. Yeah. So the ventricles inside the brain enlarge, and you have a hydrocephalus. If you are a fetus, then the skull gets larger. If you are an adult, then that then destroys your brain. So very important spot, these arachnoid granulations of Pacchione, yeah, for absorption of CSF. Okay, so back here and
Dr. Kalik,
yeah.
Can you develop hydrocephaly, or is it just something that you're born with?
Hydrocephalus is the pathological diagnosis, yeah.
Okay. So you can develop after your anatomy, right?
Sorry, can you repeat that?
Can you develop hydrocephaly after you're already like a grown-up, or it's something that you're born with?
It can develop anytime. If you are a fetus, then your brain, the head start to grow, and it destroys the brain, and you born with the destroyed brain, and depends on the severity of this affection. If it happens during adulthood, it can destroy the brain as well, and then you have a different signs of loss of your attention and dementia and other problems. Yeah, so it can develop both fetally and postnatally. Okay, now let's draw an easy scheme how to learn it. Yeah, so we will perform a sagittal view, and we will perform here a transverse view or bird's view. Okay, so we start here with crista galli, which you know is a part of the ethmoidal bone, and then dorsally we draw internal occipital protuberance. Yes, and here also crista galli and internal occipital protuberance. Yeah, so this is ventrally, and this is dorsally, and of course this is ventrally, yeah, and this is dorsally. Okay, now you may be lost, but when we start to draw, you will understand better. Okay, let's draw the unpaired one. Superior sagittal sinus. I'll go back and show you here. Okay, if you look here, a superior sagittal sinus nicely visible, coming from crista galli ventrally to internal occipital protuberance. Yeah, if you are lost, you just ask. So that's superior sagittal sinus. When it's superior, we have inferior sagittal sinus. What is in between these sinuses? Do you know? Do you have any idea? What is in the sagittal plane, even in the median plane, of course, here?
The cerebral falx.
Perfect, perfect. So here we have the cerebral falx, okay? So falx cerebri. When we come here, in here, we have structure which is in transverse plane, yeah? And it has such a shape, and we call it tentorium cerebelli. Yeah, you may remember that. So this one is tentorium cerebelli. And then continues down a falx cerebelli. And we have to draw here foramen magnum. And of course, we need foramen magnum here as well. And we also draw here sella turcica, Turkish saddle, yeah? Which you know is a part of sphenoid bone, and it houses the hypophysis, the pituitary gland. So here, sella turcica. Okay, so we have superior sagittal sinus, inferior sagittal sinus. The inferior sagittal sinus here here merges with so-called great cerebral vein, vena cerebri magna. Great cerebral vein. This is a vein which drains the depth of the brain, what is inside the brain. Yeah? For example, it drains basal ganglia, thalamus, yeah? These deeper structures. And it's formed by internal cerebral veins, so vena cerebri interna, part 1. These are two veins we will learn then during the brain. But just now understand how the brain is drained. I just draw it here, okay? So two paired internal cerebral veins forms short, unpaired, great cerebral vein, vera cerebri magna of Galen. And when the great cerebral vein and the inferior sagittal sinus, when they meet, they form a sinus which runs here. So within the tentorium, and we call it straight sinus, sinus rectus, straight sinus. And then we have sinus here, and we call it occipital sinus. And the occipital sinus runs between foramen magnum and internal occipital protuberance along so-called internal occipital crest. Yeah? Either there is a groove or internal occipital crest. So all the sinuses then finally meet here in the confluence. Yeah? So this is the confluence. And the confluence will be also here then. Confluence of the sinuses, yeah? Still everything clear, I hope. Okay, what else we need? From Turkish saddle, on the clivus, which you know is the superior aspect of the basilar part of occipital bone, here lies so-called basilar plexus, so plexus basilaris, yeah? You already know the basilar artery. Yeah, the basilar artery runs here, just lying on it. But the basilar artery is lying on the brain within the subarachnoidal space. But all these sinuses are between the bone and dura mater, so within the epidural space. Yeah, so now we are within the epidural space. And it seems that this is all. 1, 2, 3, 4, 5. Yes, 5 unpaired sinuses. So I'll come back here. And you can see the sinuses here, superior sagittal, inferior sagittal. This is rectus, yeah, this short part is rectus. And what is missing here, and I can maybe draw it here. There's the great cerebral vein, should be here. So the vena cerebri magna. Yeah, so this is the rectus sinus or straight sinus, the sagittalis inferior, sagittalis superior. This is the occipital sinus here. And this, which is not well visible, is basilar plexus. Okay, so these are unpaired. Let's come to the paired ones. So before we draw the paired ones, we have to draw the unpaired ones here, at least some of them. So we have the occipital here, yeah, the occipital here. Then, of course, if we look from above, we'll see here the rectus as well, yeah? Because they are summed. They are one above the other, occipital below, and rectus or straight sinus above. So here also be the sinus rectus. And superior sagittal sinus would be here in the middle, but I do not draw it, so it is summed too much. But of course we have here the basilar plexus, yeah, lying on clivus. Okay, so now let's talk about the unpaired ones. And for that, we use another color. For example, which one? This one. So, transverse sinus. Transverse sinus runs along the tentorium, yeah? As I said, the tentorium looks like this, and it's in transverse plane. So it runs in the attachment of the tentorium to the bone. So it's the horizontal limbs of the cruciform eminence of occipital bone. And it forms such a S-shaped structure, and we call it sigmoid sinus. And you know that the sigmoid sinus terminates in jugular foramen, and we know that the jugular foramen looks as a violin. Yeah. And what we have here is the bulb of superior bulb of internal jugular vein. Okay. Another sinus, and you know it already from arteries, is here. That's the Caverno Sinus. And inside the Caverno Sinus, we can make like a box for bottles of beer, for example, yeah, because it's formed by many small cavities. The Caverno Sinus houses in its wall internal carotid artery, yeah, and its fourth segment, which we call cavernous segment. And this you can also see here on the side, yeah. So that's cavernous sinus, sinus cavernosus. This cavernous sinus is interconnected by so-called intercavernous sinuses. So sinus intercavernosus anterior and posterior. You can say that these two are not paired because they are not left and right side, but they are paired ventrally and dorsally. Yeah, that's why we consider it as a paired one. Okay, and now we have to join these two. So we join them easily by two sinuses. And you can see a shape of petrosal part of temporal bone, yeah, of the pyramid here. So this is inferior petrosal sinus and superior petrosal sinus. Okay. Then along the lesser wing, we have a very thin, so-called sphenopetrosal sinus. Sphenopetrosal sinus. Oh, sorry, sphenoparietal. I'm very sorry. Sphenoparietal, as it comes from the parietal bone along the lesser wing of the sphenoidal bone. Yeah, so sphenopetrosal sinus. Okay. Then we have to connect basilar plexus here with occipital sinus. And we call it marginal sinus along the margins of the foramen magnum. Marginal sinus. So the marginal sinus is also in this figure. Yeah? This is cavernous sinus and the marginal sinus. Well, then we can have here a sinus, and it's variable one, not present constantly, and we call it petrosquamose. Why petrosquamose? As we can find it at the border of the petrosal bone and petrosal part and squamose part of temporal bone. Yeah, so there's the petrosquamose sinus. And I think that's all. Just don't forget we have here superior ophthalmic artery, which drains into cavernous sinus. Well, questions? I think this is not complicated. As you know, well, the skull and the grooves for the sinuses, then there are a few new ones.
Sorry, sir, can I just ask, it was the spheno, you said spheno something sinus. What was it called again?
It's called sphenoparietal, yeah, here the second last one, sphenoparietal sinus.
Thank you.
So here again, if we go through them, we can see the transverse sinus here, and the sigmoid sinus here. Oh, sorry. Back. Sigmoid sinus here. Here is the superior bulb of internal jugular vein. Yeah, and on the other side here. And then we can see the superior petrosal sinus and the inferior petrosal sinus. Then the marginal around the foramen magnum. This is the cavernous, and the intercavernous sinuses here and here. And the sphenoparietal is located here. Yeah, so you can see all the sinuses. I think that is not a complicated area. Or here from this point of view, you can see them again. So how the blood flows? The blood flows from the occipital and superior sagittal and rectus sinus here to the confluence, then to the sides, either to the left or right, transverse, sigmoid, and away through the superior bulb of jugular vein. And from the Caverno Sinus, it flows via the petrosal sinuses to the same area. Yeah. What you should know is this, which is a frontal section through the Caverno Sinus. Yeah, so the Caverno Sinus, we said, is on the lateral side of Turkish saddle. So you can see here the sphenoidal sinus, which we find within the Turkish saddle, the sella turcica. And inside there are many small cavities. They are separated by the Willis cords. But what is clinically important that in the lateral wall, we have the nerves, and laterally we have these 4 nerves, yeah, oculomotor, trochlear, and ophthalmic, and maxillary. And inside we have abducent. So in case we have any thrombosis here or inflammation, it can cause irritation of these nerves. And what will be the first symptom of irritation of these nerves? It will be the abducent nerve palsy, which causes a convergent squint. We will talk about this in cranial nerves in next week, maybe. And then, of course, palsies of the 3rd and 4th, which then cause, again, impairment of the eyeball movements, and then some irritation of trigeminal nerve. Yeah. And this can be caused not only by thrombosis or inflammation, but also by aneurysm of carotid artery in this area. Yeah? So please remember what is the content of the cavernous sinus and learn this figure, yeah, how to draw it. That these 4 nerves are within the lateral wall, and carotid artery and abducent nerve are inside the cavernous sinus. Okay, there are more figures for that, yeah, for your homework. And now this terrible slide, which tells you how the cavernous sinus is drained. So let's go through that in detail. And you can see that the main drainage is from cavernous sinus via superior petrosal and inferior petrosal sinus to transverse sigmoid sinus and to the bulb of internal jugular vein. Yeah, that's the main drainage. But the drainage can also go dorsally via basilar plexus to marginal sinuses, and from marginal sinuses through the foramen magnum. So here is foramen magnum. and then it gets outside to suboccipital venous plexus. This is a venous plexus which is in front of atlas, below the skull. Yeah? And from these originate the vertebral veins. You know that the vertebral veins terminate inside the skull as the basilar artery. Yeah? So we have two vertebral arteries which are here in this figure. Then they merge and form one basilar artery. Yeah? But vertebral veins do not exist inside the skull. They originate as low as below the skull from this venous occipital plexus. Okay. Then further ways how to drain the Caverno Sinus. It can be drained ventrally via superior ophthalmic vein to angular vein, and you know that angular artery is the terminal branch of facial vein. And then we have some emissary veins, and you know these from skull. You know that we have carotid canal, and inside carotid canal there's a venous plexus, and there's a venous plexus within the foramen ovale. So here's carotid canal, and here's foramen ovale, and you can see that they are drained to the adjacent structures. So carotid canal is close to jugular foramen, so directly into internal jugular vein, and foramen ovale opens into infratemporal fossa. And you know that in infratemporal fossa we have maxillary artery, but the maxillary vein is very short, and instead of vein there is a large, extensive pterygoid plexus. So it drains into this pterygoid plexus, which forms short maxillary artery. And then maxillary artery we know is a branch from external carotid. And I said that the retromandibular vein accompanies the external carotid artery. That's why it drains here. The last way how to drain it is via the sphenoparietal sinus to the side along the lesser wings of the sphenoid bone. Then it gets close to the bone. It gets into the diploic veins inside the bone. We will talk about them in a minute. And then from them it drains superficially to your so-called temple. Yeah. So it's then drained by deep temporal veins, which are running along deep temporal arteries, which are branches from maxillary artery. So this is not to memorize it. Yeah, this slides helps you to understand how it's complex and which areas exist. So please, this just read, think about that. Yeah, do not memorize that. Okay, this is called the danger triangle of the face, or sometimes triangle of death. In case you have any small inflammation in the face yeah, during acne, or due to acne, it can cause problems. It can enlarge, but if it's in this area, it can spread via the angular artery into the eye, into the angular vein, of course, ophthalmic veins, and into Caverno Sinus. It can cause thrombosis of Caverno Sinus. And as you can see on the right figure, yeah, there's a swelling, large swelling of the eye here, yeah, and eyelids. It's because of the blocked drainage via a superior ophthalmic vein. And it can, of course, cause death if untreated. Well, so this was for sinuses. And now all the other intracranial tributaries. So cerebral veins. We have a superficial and deep. We have talked about the great cerebral vein, which drains into sinus rectus, the straight sinus. But we have not talked about the superficial ones. So we have to draw the superficial ones here. The superficial ones drains directly into the sinuses And we can divide them into superior one. So these are superficial, better we call them venae cerebri superiores. Superior cerebral, and the inferior, which drains here. So we call these inferior. So now you may remember that we have two groups of these superficial veins, inferior and superior. Superior drains into superior sagittal, inferior drains basally, into transverse sigmoid, superior petrosal, sphenoparietal. So these are the superficial cerebral veins. They are very important in clinics. In case you have a hit into your head, what happens? You can tear the meningeal artery, the middle meningeal artery, and then the bleeding here is called epidural bleeding, and its shape is lentiform. Yeah, we have talked about this in the first lecture. But you can harm the superficial veins, which drain this way, and if you injure here them, then as they bridge this subdural space, they can cause this subdural bleeding. And the subdural bleeding has different shape as we are in a different layer. So we are between dura mater and arachnoid. And it can spread as far as the falx, which is here and here. So then the shape you can see is semilunar. Yeah, it's semilunar. It develops a bit. It develops more slowly as it's venous one from smaller veins. It's larger, but it can cause the same problem. So compression of the brain and loss of consciousness and even death. Yeah, and it has to be again evacuated by trepanation, and you have to suck it out. Okay. So this is subdural venous bleeding, semilunar shape from terminal segments of superficial cerebral veins. Okay, let's proceed. Meningeal veins, similar to arteries, not a problem. Labyrinthine veins, similar to artery, not a problem. And now let's talk about the diploic and emissary veins. Okay, the diploic veins are canals in the spongy bone. Yeah, so they are canals in the spongy bone. So they have no true venous wall. They are just the canals filled with blood, and they interconnect the intracranial and extracranial. So they are like emissaries, but not direct. Yeah, you would expect in direct emissary that it goes straight, and as you see, these do not go straight. Yeah, they just drain the spongy bone, the diploe, and we divide them according to the bones they drain into frontal, occipital, and temporal. And the temporal we grouped into anterior and posterior. Yeah, so we have 4 groups of diploic veins. That's it. Of course, they again serve as a way how to spread inflammation from externally to internally. Here's the figure for the veins, for the cerebral veins. So we can see nicely the superficial veins, yeah, which drains into superior sagittal sinus, or here into sigmoid sinus, for example. And if they are torn, they can cause the semilunar subdural bleeding. These are internal cerebral veins, yeah, vena cerebri interna. And these two then join into the unpaired vena cerebri magna, the great cerebral vein. Yeah? And they run here close to thalamus. What else we can see here? What is this one? And what is this one? Okay, number 1 and number 2. So what is number 1? Just give me the answer.
Is it basilar artery?
Perfect, basilar artery, yes, great. And number 2?
Transverse sinus?
No. Transverse sinus cannot be here. Transverse sinus is dorsally, yeah? So somewhere here would be. This is basilary. It's basal, so it's basilary plexus, yeah? That's the basilary plexus. Okay. And now the emissary veins. Yeah, long list, but you all of them you know. Yeah, from the skull. Parietal, we find in foramen parietale. Yeah, so it's this one. Mastoid, we find in foramen mastoideum. So this one. And this is clinically very relevant if you would like to approach a tumor in your posterior cerebral fossa. Then the approach is used here. It's called Retromastoid Approach. And through this approach, you can easily cut this vein and cause a bleeding, which can fill the whole operation space and you are lost. Yeah. So you have to think about this and you have to avoid opening of this vein. Then a condylar, yeah, condylaris. The condylar one. The condylar one is this one. Yeah, it runs through the canalis condylaris into the occipital condyle. Then occipital one. Of course, occipital one is here. And it goes through foramen magnum. Yeah, between the marginal sinus and suboccipital venous plexus. Close to this, we have a plexus of hypoglossal canal. Yeah, so close to this is plexus of hypoglossal canal. When we go more ventrally, we have the foramen ovale and carotid canal plexuses. Yeah? So we have the foramen ovale and carotid canal plexuses here, just below the Caverno Sinus. Yeah? This is sinus cavernosus. And then we have some smaller ones. Foramen secum very ventrally. Yeah, it would be here only in one person opened. And the Vessalian emissary through the foramen venosum, which is close to foramen ovale in 40% of cases. Mm-hmm. So these are the preformed emissary veins. But of course, the connections of ophthalmic vein ventrally, yeah, which we can also draw here. So here you can see the superior and inferior ophthalmic vein. So they also drain ventrally, so they serve as an emissary. So we have all these emissaries. Why we have them? They serve to cool the head, the brain inside. Yeah? So that's their function, that the blood gets quickly out, so it serves to cool the head. And clinically, it's important as it can serve as a way how to get inflammation from external to internal. But also it can serve, as I show you here, it can serve as a way how to get blood out from the brain. In case you have a thrombosis somewhere in important drainage area, so in the transverse sigmoid sinus or internal jugular vein, then the blood, as you can see here, this is the venous phase of angiography, and you can nicely see the superior sagittal sinus. So I label it, yeah, superior sagittal. This is confluence, transverse sinus, yeah. And you can see how the blood goes here out and then descends here extracranially. So then here in the parietal foramen, you can see how the blood goes this way out. Yes? So it can also serve serves for drainage in case of blockage of the venous drainage of the brain. Okay, question to these intracranial ones. Okay, if not, then we continue to the extracranial ones. We should draw another figure. So this I can delete, as I do not need it anymore. And we draw a new one for the internal jugular vein branching. So internal jugular vein, the superior bulb and the inferior bulb, yeah. So bulbus superior, bulbus inferior, yes, so it's internal jugular vein. And bulbus inferior, the subclavian vein, yeah, and of course the brachiocephalic. And it originates from sigmoid and from inferior petrosal sinus, yeah, and here we have the cavernous sinus. And of course, this is jugular foramen, and I will need a foramen ovale and carotid canal. Yeah, so that's canalis caroticus, foramen ovale. Okay. So now the tributaries. Well, where we start? Okay. Superior thyroid vein, yeah, the same as the artery. But we have here also middle thyroid vein. There is no such artery. So in 50%, we have the middle thyroid vein here. Just to make it all, we have the inferior thyroid vein, which drains down into the brachiocephalic. Yeah. So here we can have the other brachiocephalic left one. So it drains here as the unpaired plexus, so the plexus thyroideus impar. Yeah. So then we have pharyngeal veins. Oh, this one. Pharyngeal veins. Pharyngeal veins are more veins which drains the area from ascending pharyngeal artery. Okay, then you would expect to have a lingual vein. So we have a lingual vein, and the lingual vein receives so-called vena comitans of the hypoglossal nerve, nervi hypoglossi. That's a vein which accompanies the hypoglossal nerve and has no artery. Yeah, so it's a quite thick vein. It's even thicker than the lingual vein. And then we have a facial vein. And the facial vein, of course, gets some tributaries like submental, yeah, as we have submental artery. And then inferior labial, superior labial, and so on. And it terminates as the angular vein. Okay? Still, you can follow me? Well, now it's getting more complicated. here we have the external jugular vein. And the external jugular vein originates quite strangely from posterior auricular. As you know, posterior auricular is a dorsal branch of external carotid artery. And from another vein, and this vein we call retromandibular. And what I said about the retromandibular already twice, can you repeat it to me if you remember? What is a retromandibular vein?
It drains into the internal jugular vein.
Not directly. It's the vein which accompanies the terminal segment of external carotid artery, yeah, within the parotid gland. That's why retromandibular, it's in this area behind that. And this retromandibular vein bifurcates. You can see now the bifurcation which I draw. It bifurcates, yeah. It bifurcates into posterior division, divisio posterior, which drains into external jugular, and it bifurcates into anterior division, divisio anterior. Do you know any other vein which bifurcates? One large vein, very large vein.
The common iliac.
No. Common iliac does not bifurcate because common iliac vein is formed by confluence of external and internal iliac, and then it joins the contralateral one and forms the inferior caval vein. Yeah, but which bifurcates into right and left. Yeah.
Portal vein before it enters the liver.
Great, portal vein, yeah. And then we have another smaller vein concerning the genital organs which bifurcate. You may know. It's the deep dorsal vein of penis or the deep dorsal vein of clitoris. Yeah? It bifurcates. One of them drains into internal pudendal and the other division drains into pudendal plexus of Santorini within the retropubic space. Yeah. So now you know 3 bifurcating veins. This is just to summarize the knowledge. So you can see that the retromandibular bifurcates into anterior and posterior division, and the anterior division then merges with facial vein, and sometimes we call this as a vena facialis communis, common facial vein. Yeah, that's this terminal segment of the facial vein after merging with the anterior division of retromandibular. Okay, how the retromandibular originates? It originates from superficial temporal and maxillary. Yes. Into this confluence, there usually drains another 2 veins, and that's the transverse facial and middle temporal. You know, these are smaller branches, the arteries are smaller branches of superficial temporal, yeah? But as veins, they usually drain into the origin of the retromandibular. So it's like 4 veins meet in one point or close to each other, yeah? Maxillary, superficial temporal, and 2 smaller, middle temporal and transverse facial. Maxillary one, as we said, is a very short one, and instead of that, we have a pterygoid plexus. Yeah? Pterygoid plexus. Inside infratemporal fossa. And how the pterygoid plexus is now, how it gets the venous blood. So for example, from infraorbital vein, yeah, but also from venous plexus of foramen ovale, yeah, which is an emissary. And also from the eye, inferior orbital vein, or ophthalmic vein. So vena ophthalmica inferior. So we can make here an orbit, yeah. So this is orbit. And of course receives many other, like middle meningeal, for example, middle meningeal vein, and so all the other veins which are similar to arteries. So some more connections. Here is a vein which connects pterygoid plexus and facial vein. We call it profunda faciae, so deep facial vein. It is not a perforator, even it goes from depth to surface. The facial vein is a normal vein. Yeah? It is not a superficial vein. It is quite deep, but still pterygoid plexus is deeper. So this is just a vein which interconnects. And it passes here through the buccinator muscle on the face. Then we have here a plexus. This venous plexus of carotid canal drains into internal jugular vein. We have superior ophthalmic here. So ophthalmica superior. And these two veins are connected to angular. And that's the way how we can spread inflammation from face into the eye. Yeah. So what we miss? We miss occipital. And the occipital drains into vertebral. And you know that the vertebral drains into brachiocephalic. And the vertebral originates as plexus venosus suboccipitalis, suboccipital venous plexus, which connects to marginalis sinus via oval foramen. So you can play with the scheme as you want to see all the connections. Yeah? Okay. So then you see that the occipital vein drains into vertebral, which you would not expect, as occipital artery is branch of external carotid. And then the last vein is here, anterior jugular, and it drains into external jugular, yeah? And it's connected to the other side here by a vein which in suprasternal space can also complicate the inferior tracheotomy. What is the name of this vein, which is here from the left to the right side in suprasternal space, and you have to ligate it during inferior tracheotomy? You remember the name?
Anterior jugular vein?
No, anterior jugular vein is this one descending down, but how we call this?
Venous arch.
Yeah, jugular venous arch, yeah? Arcus venosus jugularis, perfect. Jugular venous arch. So now you see the scheme quite complete. And this is again a textbook scheme. So the areas which are usually variable, yeah, I'll just draw them for you so you can see that here the veins can drain differently. Here the veins can drain differently. And here the veins can drain differently. So if you look into different books, you can see different figures. I will show you some examples during the presentation, yeah, just to see. But there should be some textbook pattern which we use as a reference. So this is the reference. Yeah, that's why I went through all the detail in this scheme, so you understand it, what we consider a reference. Okay. And then back here. So what we can see here in this figure, superior and inferior ophthalmic artery, how they are interconnect with angular not arteries, of course, veins, I'm sorry. Superior inferior ophthalmic veins, how they are connected to angular vein and then to facial vein. Yeah. So what you can see here, it just shows us how the superficial veins of the head can be either abundant or how they can be scarce. But the number one shows us superficial temporal vein here. And then when we come to some figures, just to highlight the main veins. So we have the anterior jugular, as you can see here, originating in submental triangle in this area. And it can be connected to submental vein here. The anterior jugular drains into external jugular. So the external jugular is here. And I said the external jugular originates from posterior auricular and posterior division of retromandibular. Yeah, as you can see here. The anterior division is then merged with the facial vein and forms the deep facial vein. And what is this? Communicating vein, this one, yeah? So there can exist such communicating vein. For example, in this figure, you can see it. Yeah, in the majority of patients, you do not see it. How is it with the occipital vein? You can see the occipital vein, how it drains deep then, and it's not visible farther how it gets into the vertebral. But there's a communication here between posterior auricular and occipital vein. Yeah? Again, a no-name communication. Okay, what else you can see here down? Transverse cervical and suprascapular veins. I just forget to draw these, so we go back to the scheme. And we have to draw these here. I use a different color. So usually into the external jugular vein, there is this suprascapular and transverse cervical. Can you tell me from which artery, these two arteries, if in case they are arteries, from which artery they branch from? The transverse cervical and suprascapular. You remember?
Thyrocervical trunk.
Perfect, thyrocervical trunk. And you can see the drain into external jugular vein. Yeah. So this is another important information. So when we come to this figure, for example, yeah, again, we can see the facial vein, the posterior division of retromandibular, and then the common facial vein into internal jugular. Posterior division and posterior auricular together, external jugular. Yeah, and again, here communication between the occipital and posterior auricular. And then in here, you can see this unnamed vein on the lateral aspect of the neck. Okay, so every figure shows you a different situation as veins are variable. Okay, this shows you the pterygoid plexus, how it can be either rich or scarce in this situation. And of course, we can see here another vein I have talked about, and that's here, and that's the deep facial vena profunda faciae, deep facial vein between the pterygoid plexus and facial vein. And another figure showing you pterygoid plexus here, and the deep facial vein here. And what else we can see here? Very short retromandibular, yeah, very short retromandibular. And here occipital vein and posterior auricular vein, they join and form the external jugular. So there is no connection to vertebral vein. And you can see that the posterior auricular here is divided into two branches. So this is again a situation with different. So it is not easy to be oriented if you just follow the typical branching scheme as you have learned in arteries. Yeah? So you have to think more about where the vein runs, yeah, according to the topography, where you find it exactly, and not only how it's branched or where does it drain. But don't worry, in the test, we do not ask about these variation details. Yeah, this is just to show you that when you see a patient or a cadaver, that it can be complicated. Okay, in all the veins of the head and neck, there's a risk of the air embolism, but the larger the vein is and the closer to the heart it is, then the risk is higher. So of course, don't forget that the risk is also in external jugular, internal jugular, but also in the unpaired thyroid plexus. Yeah, during the tracheostomy, you have to close the veins quickly. Okay, another clinical point is central venous catheterization. So for this, we can use the terminal segment of internal jugular or terminal segment of subclavian vein. Yeah? The subclavian vein we can approach above clavicle or below clavicle, more commonly below clavicle. For the central catheterization, we can also use another veins, femoral vein, mainly in case we are not able to access the first two mentioned, and then rarely axillary vein or even external jugular. And in newborns, where you have the stump of the umbilical cord, you can use the umbilical veins as well. Of course, if you approach here the internal jugular or the subclavian vein, you can cause some troubles. In any approach into the body, you can cause infection, of course. But as we are close to cupula of pleura, you can cause pneumothorax or hemothorax. Yeah, and these are the most common complications. You can injure the brachialis plexus. You can, of course, perform the air embolism here. And why to perform the central venous catheterization? It is a permanent venous approach which you use because the central veins are very large, so they do not collapse totally. Yeah, the peripheral veins during shock, they collapse, so they are too small, and sometimes you are not able to perform catheterization. And you use it for application of large volumes as the vessels are large. Yeah, application of parenteral nutrition, application of adrenaline or adrenaline dopamine, so the catecholamines when you would like to maintain the blood pressure, cytostatic and 10% glucose. All these four substances or groups of substances, they irritate the venous wall. And if you use the small caliber veins in periphery, these veins can get easily infected and thrombotized. Yeah, so that's why we use the central approach here. It's also used in dialysis. It's also used for monitoring of venous pressure inside the right atrium. So clinically very important. What you can see here on this X-ray, I will ask and you will give me the answers, okay? So what is this? And this, and the wires. Of course, all of you knows that this is the heart, yeah? But what is these small circles? No idea? It's ECG, electrocardio, myograph, and just the wires, yeah? It's usually in every patient in emergency. What is this shadow?
Is it a tracheal tube?
Perfect, endotracheal tube, as you can nicely see here, the trachea, yeah? And even the bifurcation of the trachea here can be seen. And what is this? That's the central venous catheter, yeah? So this X-ray is performed as you can see how it's performed. And here you see another case. Not so nice, but still nicely visible how the catheter runs inside the right atrium. But if you come to this one, you can see the difference. Yeah. Here are the, this is the trachea, and the wire goes totally away. Yeah. So this is a subcutaneous localization, and you have to perform the catheterization again. Here it's placed finally well, and again you can see the endotracheal tube and the wires of ECG. Okay, I said the dialysis is performed there, yeah? And for dialysis we can use this. This is called the tunneled central venous access, yeah? That you put a permanent catheter here, and subcutaneously you get it into the subclavian artery. But we have this approach, but what we prefer are first peripheral approaches. So for the peripheral approach, we can produce an arteriovenous fistula, and this arteriovenous fistula can be either natural, so you use your own vessels, or you put there a prosthesis. Yeah, as you can see here, a graft. So we can use a cephalic vein. We cut the cephalic vein and we join it together with the radial artery. Yeah. So here then you have the fistula, and all the time you would like to perform dialysis, you put a needle inside this fistula. So then that's the most common, which is called radiocephalic fistula. If it doesn't work, you can perform it in the cubital fossa, where you use the perforating veins of Gratz. Yeah, we have a perforating vein here, cubital perforating vein, and in between the median cubital vein and radial artery, you can produce this cubital arteriovenous fistula. Of course, we can use different ones. When these get closed, you can use ulnocephalic, brachiocephalic, brachiobasilic, even in lower limb tibiosaphenous. They are not used much. So this is another important information. And here you can see how the fistula is shown by angiography. Yeah? And here you can see how the fistula looks when it's performed by surgery. Of course, then the vein, the cephalic vein, suffers from higher blood flow and a higher blood pressure. Yeah, as you get the arterial blood directly into the vein. So the venous wall cannot withstand this pressure, and it gets thrombotized, as you can see here. So after this, you have to change the site for dialysis. That's why we can perform more these fistula. And slowly we get to the veins of upper limb, which are easy for you, you know all of them. So you know we have two system, superficial, deep. For deep, it's very easy as it accompanies the arteries. It's doubled up to the axilla. There are frequent valves and frequent mutual communications. Yeah, and clinically it is no relevance for that. Remember that subclavian vein has got only very small tributaries, and all the branches from subclavian artery, all the corresponding veins drain into external jugular or brachiocephalic vein, yeah, not in subclavian vein. And for the superficial veins, I think it's not a problem. You know the cephalic vein on the lateral side, draining here in clavipectoral triangle. You know the basilic vein on the medial side, draining in or submerging in basilic hiatus and then draining somewhere within the arm or as far as axilla. We have median cubital vein which interconnect these two, and antebrachial vein which runs in the midline of the forearm. All these originate dorsally. Such a nice network of veins is not present in the palm, but dorsally. So they originate in a dorsal venous network. And the palmar veins and dorsal veins are interconnected by intercapitular veins between heads of metacarpal bones here. New veins for you are these two, costoaxillar and thoracoepigastric. Costoaxillar are smaller veins from intercostal spaces, first, second, third to axillary vein. But very important are these superficial veins, thoracoepigastric, which drains the area of thorax and superior abdominal area, so the hypochondria, into the axillary vein. Yeah, and we will need this in some minutes. So do you have questions to head, neck, and or superior upper limb veins?
I just have a question. Since we're having anterior jugular veins, do we have any posterior or?
No.
Okay, thank you.
You're welcome. Now we are going to talk about the veins of thorax. And in thorax, it's a strange situation as we have large artery, aorta, but the superior and inferior vena cava drains into the heart, and we miss here a large vein, and it is supplied, it is replaced by azygos and hemiazygos and accessory hemiazygos veins, so-called azygos vein system. So what is an azygos vein? Azygos means an unpaired. Yeah, as we have a large unpaired vein on the left side, and then a smaller counterpart. Sorry, I said on the right side. I'm sorry. Large azygos vein on the right side, and then small counterparts, hemiazygos and accessory hemiazygos on the left side. We find them within the mediastinum, and you can see nicely the relationship here of the azygos vein to pulmonary hilum. It is dorsally to the hilum and cranial to the hilum, and it forms a groove on the right lung. Yeah, it originates in abdominal cavity just below diaphragm by a confluence of ascending lumbar vein and subcostal vein. Yeah? Subcostal vein is a counterpart of subcostal artery, and ascending lumbar vein is a vein which you can see here. It's a vein hidden behind psoas major and connecting azygos to common iliac. So we are going to draw again a scheme to help you. I hope that the scheme helps you. If not, you just have to tell me, stop it. Okay, so azygos and draining into superior vena cava. So this is superior vena cava and azygos. And azygos originates from subcostal and ascending lumbar. And the ascending lumbar drains into common iliac. So then these two common iliac join and forms the inferior vena cava. So then we need a diaphragm. It's a scheme, so here you can see that the diaphragm is quite far from the heart, yeah, but it's just a scheme. Okay, so now some tributaries. We will have here tributaries, which we call easily posterior intercostal veins, similar to arteries. But from the second and third intercostal space, they form one vein. This vein we call superior intercostal. Superior intercostal, yeah. And then from the first intercostal space, we have a special vein which we call supreme intercostal. Supreme like the highest. And the supreme drains into usually into brachiocephalic. Yeah. Of course, there can be a communication, and these areas can be arranged differently. Okay, how is it on the other side? I do it with a different color. Yeah. So we have hemiazygos here. It originates in the same manner. So from subcostal, yeah, it gets here some intercostal, of course, intercostal posterior ones. And it drains into azygos somewhere at the level between the 7th and 9th thoracic vertebra. So if we open a cadaver, we usually do not see it, as the diaphragm forms a vault, and the vault is at the level of the 4th on the right side and 5th on the left side intercostal space ventrally, and dorsally it descends. And if you have in the cadaver or in patient, if you have their liver, the stomach and spleen, then you do not see well behind the diaphragm. Yeah, so these communications can be seen only if you remove these organs and move the diaphragm away. So in cadavers, it is not so easy to see. What you can see is this quite thin hemiazygos accessoria vein. So accessory hemiazygos, yeah, which also drains some of the intercostal spaces. But how it's arranged here up? Here up, we have again the first, which comes via the supreme intercostal into brachiocephalic. And then we have the second, third, and even fourth one, which drains also cranially, usually. And then we call intercostal superior left vein, yeah? And there are communications, of course. So you can see the difference that on the right side, majority of the blood goes down into the azygosystem. On the left side, first 4 intercostal spaces, or 3 or 4, can be drained cranially into brachiocephalic vein, yeah? And the hemiazygos accessoria is not so long. Okay. Now, how is the situation here caudally? We have here lumbar veins. Yeah, I think you remember lumbar arteries. Yeah, as lumbar arteries are branches of abdominal aorta, and the lumbar veins are usually here connected to ascending lumbar vein. So how the blood flows? The blood flows here caudally, here cranially, here medially, and in this area, it depends, it is individually different, yeah? It can go either up or medially or down. So this is a strange area, and of course, this is a strange area. Yeah, here can be difference. And of course, here the level 7 to 9 is also differing. So this system drains the posterior, superior, and posterior mediastinum, and it drains the retroperitoneal space, yeah, and interconnects the superior and inferior vena cava. So this serves as a cavo-caval anastomosis, as there are no valves in this system. Okay. Question? If not, there are some figures to show, and it's also in every book. You can see it's drawn differently. Yeah, so we have talked about some reference model. So you can see here the supreme intercostal, how it's connected to superior intercostal on the right side. On the left side, there's even drawn such a channel. Yeah, such a direct channel, which usually does not exist. Here you can see the lumbar veins, how the lumbar veins interconnect the azygos, hemiazygos with the inferior vena cava. So these are the tributaries, and we have not talked about the visceral ones. We should not forget that we have the visceral tributaries as well. Yeah. So in the scheme, we should of course add some visceral tributaries. Esophageal, in the upper area, of course, bronchial veins. Some of the bronchial veins drain here, some of the bronchial drains into pulmonary veins, and small mediastinal veins which drain the lymph nodes, the nerves, the connective tissue, and the adipose tissue here. So esophageal, bronchial, and mediastinal. Yeah. So do you have question to the system of azygos and hemiazygos veins? If not, just close to it are veins of the vertebral column. It is very easy as there are plexuses. Yeah. And we know that we have the plexuses located named here according to their position. So we have the anterior external, we have the posterior external. We have the anterior internal and posterior internal. And they are mutually connected. And these connections, which goes via the vertebral bodies, we call basivertebral veins. And these veins, as they are inside the bone, they also do not have their proper venous wall like the diploic veins. They are just canals inside the bone. And all these plexuses, they do not possess valves. Yeah? So then the blood can flow in either directions, either down or up. And it's very important that it can serve for spreading of inflammation and mainly spreading of metastasis. Yeah? And if you find a metastasis in the vertebra, you have to look for a tumor, but you usually look for a tumor of the lung, of the rectum, of the lungs, of the breast. And in clinics, the system of these plexuses along the vertebral column, we call them Bateson's plexus, and it's another cavo-caval anastomosis. Yeah. So that's it. If you operate in this area, don't forget that also these veins can serve during the operation as the entry point of the air embolism. Yeah, it's close to heart here, so the blood pressure is also very, very low. Okay. Then we continue into the abdomen, inferior vena cava. Inferior vena cava, very complicated embryological development. Yeah, it develops from 4 different veins, and I leave this for embryology. But the anatomy is quite easy. Yeah, it originates at the level of L4 by confluence of common iliac veins. It terminates in the right atrium, just after passing through the foramen of vena cava of diaphragm. It has no valves. It is located right to aorta. It's right-sided. Yeah, it's primarily within retroperitoneum as aorta, kidneys, supranal glands, ureters. But what is important, we find it. What is also important, we find it dorsally to liver and even a bit inside the liver. Yeah, it's impacted in this groove. There is a small ligament here in this groove, and of course it drains liver. So then the caliber below liver is 2 centimeters, and above liver, when getting all the blood from unpaired abdominal organs, it's 2.5 centimeters, which make it the largest vein in the human body. Yeah? So that's the topography. And now let's talk about the branches. This is the view from dorsally. So you can see the lumbar veins, how they are connected by the ascending lumbar vein here on the sides. And from the anterior aspect, the classical arrangement. So which are the branches? Yeah, you can again draw a scheme, but I think it's not necessary here, as we have the branches similar to the arterial side, or I can draw it here, just next to it. So it originates from common iliac. It's shifted to the right side. So the median sacral vein, just to go together with the medial sacral artery, branch from aorta, is draining into the left common iliac vein. Yeah, I hope you understand this, why it's like that. Yeah, as the vena cava is on the right side and aorta on the left side. So when we have here the artery, then the vein has to drain here. Okay, we have parietal and visceral branches. So let's start with the visceral branches. Of course, we have the renal ones. And don't forget the relationship of the left renal vein. It is between superior mesenteric artery and aorta. So it can be entrapped, and we call it nutcracker syndrome. You may remember that we have talked about that last time. Yeah. So left renal vein is between aorta and superior mesenteric artery. Okay, suprarenal gland. How many arteries supply suprarenal gland? Can you tell me?
3.
Perfect. And we have only one vein. Only one vein, yeah? On the right side directly. On the left side, because it's too far, it goes into renal. Yeah? And from below, we have the testicular or ovarian vein. Again, on the left side, it drains into the renal. On the right side, directly into inferior vena cava. And then, of course, liver, and from liver, 3 veins. Yeah, right, left, and intermediate. And now the easiest, 4 lumbar, paired. Don't forget to, or paired inferior phrenic. Similar to arteries, yeah, not a problem with that. So, I said that the development is very, very complicated. So what can happen is the left-sided inferior vena cava, usually in the infrarenal segment, yeah? But it can be even doubled. And this is important to know. Another variation is that the inferior, the left renal artery can run behind the aorta. So it can be entrapped by aorta, or it can be entrapped between the aorta and vertebral column. Yeah, then we call it retroaortic left renal vein. So there can be some clinically quite relevant variations. There exist many anatomical variations which are then not so clinically important, as just as example, as you can see here, how the situation can be complicated. Yeah. And sincerely, I do not know the percentage of these. Even I'm an anatomist, I just sincerely do not care about how these are common, as it is not clinically so relevant. But what is important are these segments. Based on the embryology and the complication of the development, as I said, some of the segments can be doubled or left-sided. You should know that we have infrarenal segment. And then the infrarenal segment is the longest one. Yeah, so there's this area. Then it's very short renal segment. Then we have suprarenal segment, the second largest. And we have another 2 short segments, hepatic, which runs in the groove of the vena cava. And then above the diaphragm, of course, we have the thoracic segment, yeah, the shortest, or as short as the renal one. So please remember, we have 5 parts, 5 segments of the vena cava inferior, and especially the infrarenal can be doubled or left-sided. Okay, what you can see here on the X-ray and here down, this umbrella, this we call a green field filter. In case we have a patient who suffers from a thromboembolic disease and the anticoagulation treatment does not help, or there is a contradiction of the anticoagulation treatment application, then you, via femoral artery, you insert this filter, and this filter should stop larger thrombi to get into lungs and cause pulmonary embolia. Yeah, so this is another clinical situation you may know. But most common problem with the inferior vena cava is in pregnancy. In the last trimester, the large uterus can compress the right-sided inferior vena cava. That's why the pregnant lady has to change the positions often. Yeah? But the inferior vena cava can be compressed also by tumors, by aortic aneurysm. Yeah, and there can be, of course, thrombosis even in inferior vena cava. So that's just the clinical point of view. And another important clinical point of view is here. We just continue to the common iliac vein. And you can see that based on the right-sided position of inferior vena cava and left-sided position of abdominal aorta, the right common iliac artery compresses the left common iliac vein against the vertebral column. Yeah, this is a normal situation that it's compressed, but in case you again suffer from thromboembolism, thrombosis can develop here. Then it's called May-Thurner's syndrome. Yeah, May-Thurner's syndrome, and we solve it easily. We put a stent here to enlarge the compressed area. Yeah, and the typical patient is a lady in the age between 15 and 30 with anticoagulation problems, maybe using the hormonal anticonception drugs. So you would expect if first thrombosis appear, it would be in lower limb veins, but it can even appear, especially in this group of population in this area. Yeah, so you have to treat it carefully as the pulmonary embolism is a danger. Okay, do we have any branches of the common iliac artery? The answer is only the terminal. The question, do we have any tributaries of common iliac vein? The answer is, of course, we have the internal and external iliac vein, but then we have the ascending lumbar, which is paired, and sacral median, which is unpaired. Yeah. So, in case in this figure, when I edit here, we have the middle sacral here, yeah, draining into the left common iliac vein, and we have two ascending lumbars. You can see one here, and the other would be here, which drains caudally. I said these two are hidden behind psoas major, so you cannot see them. The only thing you can see is the terminal segment. Yeah, we will show this during the dissections, this terminal segment of the ascending lumbar vein. The rest is hidden behind psoas, but of course you can see it on imaging methods.
The Idiolumbar veins, in memory it says that they're going to the that they're draining to the common iliac.
They can either drain here into common iliac, or they can drain here into internal iliac. Yeah, so it's variable here or there.
Okay, thank you.
So external iliac, it has no tributaries except for the two which mirror the arteries, so the inferior epigastric and deep iliac circumflex. Inside there can be present valves in 20%, and you can see this is quite a strange valve. Yeah, you can see two cusps above the other. And it can be dysfunctional, this one. Yeah. Here in the circle, you can see the corona mortis. So that means the aberrant accessory obturator vein. Unlike the artery, which is present in 25%, the venous one is present up to 90%, but clinically relevant caliber is present in 75%. That means larger than 2 millimeters approximately. For internal iliac vein, the parietal branch is similar to parietal arteries. Visceral branch is similar to visceral arteries. But main difference is that around every organ we have a plexus. So then it's easy. The name of the plexuses, they are similar to name of the organs or identical. So we have a vesical and prostatic, uterine and vaginal, and rectal. Of course, do not forget that the rectal plexus we call external rectal plexus, as we have within submucosa internal, which we call hemorrhoidal. And we know that the function of this hemorrhoidal or internal rectal plexus is to maintain contination. Yeah? Maintain contination, that means it helps to keep the stool inside the rectum together with the muscles. And then we have two, which are ventrally is one, that's pudendal, and dorsally is the other, which is called sacral, between rectum and anterior aspect of sacral bone. Yeah, so we have sacral and pudendal venous plexus. And that's it. Why we should know that there are plexuses? Of course, if you operate, you have to avoid cutting these plexuses. And there are some other important clinical situations. In pelvic fractures, these plexuses are easily torn and they can cause heavy bleeding. You can die due to bleeding into the pelvic cavity. In the plexuses, the blood flow gets slower and slower. It can even stop. So thrombosis can develop and it can cause embolism. The thrombi can uptake calcium and we can then see small stones, like stones there. So small spots of calcium. It is normal. Yeah, you just consider this normal. You do not mix it with the small stones, which we call coprolites inside colon and rectum. The veins of pelvis are connected to veins of lower limb. So at the varices of the lower limb, when they are heavy, they can spread into the pelvis, and I'll show you through which spaces. Okay. Here you can see an easy scheme of the venous drainage of pelvis. This is not for you not to learn it. This is just to show that we have here some plexuses and that here are mutual interconnections. Yeah, so we have the plexuses and these plexuses are drained, and they are drained not only by corresponding veins, but they are also drained along the ovary into the ovarian vein and inferior vena cava. Yeah, they are drained from rectum also along superior rectal vein into inferior mesenteric vein and portal vein. And they are drained via external genital organs. They can be drained externally. So deep external pudendal vein, superficial external pudendal vein. And you can see that there are connections also between the circumflex femoral veins and inferior gluteal vein and perforating veins here. Yeah? So there are mutual interconnections. And we are going to talk about this, which is a vein of round ligament of uterus. And you can see that this vein of round ligament of uterus interconnects the uterine plexus with the external organs, and it runs through the inguinal canal. Yeah? The artery of the round ligament of uterus is branch of the inferior epigastric artery. And this vein can serve as a channel interconnecting varices of lower limb and varices of the pelvis. And it's then joined with the ligaments of broad ligament. The broad ligament has got many small veins in it. And when they are enlarged in pelvic varices, you can see these veins using ultrasound, for example. And then a very interesting vein is sciatic vein. The sciatic vein is a tributary of inferior gluteal vein, and it can continue on the posterior aspect of the thigh. Yeah, and it's a developmental remnant of an axial vein, and it can persist and can be visible by ultrasound as well. Yeah. So here are the veins you do not find in the books, and you would consider them small and not interesting anatomically, but clinically they can be relevant. Yeah. So this is just to inform you about these. Here you can see how the normal vena ischiadica or the sciatic vein looks like, but it can be enlarged several times. These figures just demonstrate how the vein looks here, so it's for your self-study. And here we have 4 points which can be examined by ultrasound in case of pelvic varices, and you would like to find the way or the direction of the blood flow there. So in inguinal canal, there's the vein of the round ligament of uterus. Yeah, so you can see how the uterus is connected with the Brachiocephalic vein. Obturator canal is another direction. Yeah? Obturator vein, which drains into the internal iliac, is then connected to the femoral vein by connections. Infrapiriform foramen contains the inferior gluteal vein, which can be connected to sciatic vein, as we have talked about. And then perineum itself, the perineal area, so between vagina and anus, here are small veins, and this area is drained dorsally by internal pudendal vein and ventrally by external pudendal vein. Yeah, so here this is the area where most commonly the varices develop during pregnancy or after pregnancy. Okay, so this is just another clinical view of anatomy. Okay, hepatic portal vein. Again, nothing new for you, so we just repeat it easily. As I said, it drains all the unpaired abdominal organs, that means GIT and spleen. There are no valves, and we should draw the main tributaries here. Yeah, so let's do it. Okay, liver, and then into liver portal vein, splitting into a left and right branch, and originating as the splenic and superior mesenteric. Okay, the inferior mesenteric usually drains into splenic in some 50%, but it can drain into the origin, into the confluence of the splenic and superior mesenteric, or it can drain into superior mesenteric. All this is hidden behind the head of pancreas. But if you operate, if you see an imaging method, you should not be surprised that the inferior mesenteric artery can terminate in the other situations. And you can see that the incidence is quite high. Okay, what about other tributaries? So we have left gastric and right gastric, which forms an arch. Yeah, we know the arterial gastric arch along the lesser curvature. So then we have the right gastric and left gastric. And this arch, nicely formed, is called in clinics coronary ventricular vein. Yeah, why coronary ventricular? Ventricle is an old term for stomach, and coronary, you can see how it forms a circle, a crown, yeah, like coronary arteries of the heart. So if you hear coronary ventricle vein, it's a clinical obsolete term for this. Okay, then we have another one, which we call pre-pyloric vein. And pre-pyloric vein of Mayo. Mayo is the founder of the Mayo Clinic, and he was anatomist. Then we have a cystic vein. Cystic vein drains into the right branch of hepatic portal vein. And then we have so-called paraumbilical veins. They are two. They are so small that you even do not see them. They run within around ligament of liver to the umbilicus. And they just drain the ligament and surrounding tissue, so they are not important normally. They are very important during portal hypertension. Yeah. Okay, so that's the normal arrangement of the portal vein, hepatic portal vein tributaries. Here you can see nicely the venous arch between the right and left gastric vein here. I should not erase it, as I forget to add something. So I can edit now. Here we have a vein which we call a gastropancreatic trunk of Henle, gastropancreatic trunk. And this gastropancreatic trunk is produced by 4 veins. It is right colic, colica dextra, right gastroomental, and inferior pancreaticoduodenal. This short gastropancreatic trunk appears just below pancreas, and if you operate here and you would like to perform operation on pancreas or duodenum, this gastropancreatic trunk is not much movable, and there's a danger of making a rupture and cause a bleeding from this. Yeah? And you can see how these 3 veins make a strange confluence and drain into superior mesenteric. Yeah, this is the superior mesenteric. Well, this is also not written in many books, and it's clinically relevant. Yeah, we don't ask about this in the test, but you can remember this gastropancreatic trunk of Henle. Okay, now we can continue. And the trunk is I think cut here. Yeah, there's 22. That's the trunk. Again, we can see here the venous gastric arch, right and left gastric vein, and here even the venous gastroomental arch, yeah, between the splenic vein and here then the superior mesenteric vein. Now we should talk about the portocaval anastomosis. I know you know some of them already from GIT, but it's time to draw again a scheme. So we need a liver. And then we need a portal vein. So we have the splenic and inferior mesenteric and superior mesenteric. Okay, then we need the heart. And we need inferior vena cava and common iliac, and then we need the external iliac and common femoral, and we need the internal iliac. And of course we need superior vena cava, and the brachiocephalic, and the subclavian, and the axillary. Okay. So why we should talk about that? In case we have a problem in the circulation of the portal hepatic portal vein, that means it's blocked, and it can be blocked by thrombosis in front of liver, which is usually called a Budd-Chiari syndrome, or it can be blocked by thrombosis in hepatic veins, or most commonly by cirrhosis in the liver. Yeah. Then the blood cannot go so easily through liver. The patient suffers from portal hypertension, so then the blood is stuck in front of liver. So what happens? What happens is
necrosis?
No, necrosis does not happen. But what happens? I just wanna
Elevation of the vessels.
Now you see the screen finally. Yeah. So when we have the portal hypertension, it can be prehepatic or posthepatic thrombosis, yeah, or in hepatic cirrhosis. So we have hypertension, and what happens is ascites, that we have too much fluid in front of the liver. The fluid starts to filtrate into the peritoneal cavity, and we can have up to 40 liters of the fluid there. Splenomegaly. Yeah, the blood stays in the spleen and it's enlarged. And then, of course, the blood has to be drained somehow. So the portocaval anastomosis start to open. And the portocaval anastomosis, then they can cause some problems. They can cause problems with bleeding in esophageal varices and in hemorrhoids. And they can cause what we can see here, such bulging and prominences on the skin, which we call a caput medusae. Why caput medusae? You can see this head of mythic Gorgona. Her name was Medusa, and you can see the snakes here instead of the hair. And if somebody sees the face of her, gets petrified. Yeah. And the Greek hero Perseus, he saw her face in his shield, so not directly, and then was able to cut her the head, and and that's it. So that's why we call this caput medusa. Yeah. And now the anatomy behind the story is here. So first, the esophageal varices. We have here the left gastric vein, and the left gastric vein has got some esophageal branches. And then the esophageal veins are drained into azygos and hemiazygos vein. Yeah. So that's one route, and this route has two layers. One layer is within submucosa. When it's within submucosa, the submucosa, as you know, is a loose connective tissue. And if you get here enlarged vessels, what happens? Then the vessels has to spread somewhere. So they can spread either externally, but there's the muscle layer, so they spread internally. And you can see it during examination by endoscope. So you can see such bulgings, usually at numbers 3, 7, and 11. And these bulgings are there. And there's a danger because you still swallow that the food can mechanically cause bleeding. Yeah? And when you have bleeding, the bleeding is usually profound, it's dangerous. So you need to stop it quickly. So you use this Sengstaken Blackmore 3-way double balloon tube. Yeah? One balloon to block the tube in the stomach, the other balloon to be inflated to close the bleeding, and the third tube goes into stomach to suck out the fluid from stomach. Yeah? It can stay there for 24 hours, and then you have to remove it. If it still bleeds, you can come to endoscopic ligation or sclerotization. Sclerotization means that you, into the veins, you just instill for example, alcohol or any sclerotization solution which cause constriction and fibrotization of the vein and closure. Yeah? But esophageal varices are dangerous as they are the terminal stage of portal hypertension, and usually the patients die within 1 year. Yeah? So these are submucous ones, and you can have paraesophageal varices. That means in adventitia. They easily extend into mediastinum. They do not produce problems. You just see them on X-ray. Yeah. So please remember, and we have two layers here. So we can have submucous and adventitial. Yeah, and of course the submucous are clinically very relevant as the esophageal varices. Okay, when we have this on one side, we can have it on the other side of the digestive tube. So we have here superior rectal, and the superior rectal then again communicates with the veins, and these veins are middle rectal and inferior rectal. And inferior rectal is a tributary to internal pudendal, yeah, according to the arteries. I'll just make here the points where there is a branching. Yeah? Here is also a branching. And these, they can produce hemorrhoids, yeah? External and internal hemorrhoids during the portal hypertension. So these two, I think you know, and it is not a problem. And then here we have the paraumbilical veins, yeah? Two small paraumbilical veins of Sapei, which comes to umbilicus. Before they come to umbilicus, there is a connection between urinary bladder, vesica urinaria, and umbilicus, and we call it ligamentum umbilicale medianum, yeah, the median umbilical ligament, or we also call it chorda of Urachus, yeah, Urachus cord, because it's a remnant of the Urachus, and Urachus connected the yolk sac and urogenital sinus or cloaca before a connection. It's closed, but the veins here exist. So here we have a connection, and this connection goes into the vesical venous plexus, and then into internal iliac vein again. So I have to go somehow into internal iliac vein. How to do it? Yeah, vesical veins. And we call these veins Burov vein. So the veins along this ligament, Burov's veins. And if you would like to open the abdominal cavity using the midline section, yeah, the median laparotomy, then of course it can bleed more than usual, because in the midline you have to cut these veins. Okay, if not here, then we can get more superficially to the muscle. And we have here which muscle? Which muscle looks like this?
Rectus abdominis.
Perfect, rectus abdominis. And you know that rectus abdominis is drained by inferior epigastric and by superior epigastric. And the superior epigastric drains into internal thoracic. Yeah? So these muscular muscles, the muscular veins, can also serve, and it can drain either caudally or cranially. Or it can get under the skin, and here it can cause the caput medusae by enlarging the subcutaneous veins of abdomen, which then drain caudally into great saphenous vein, and this tributary is superficial epigastric vein, yeah, corresponding to the same artery, which is branched from femoral. And cranially, it goes into the new veins we have learned, thoracoepigastric veins. And it can drain also to the lateral thoracic and costoaxillary and to some other ones, but mainly thoracoepigastric and axillary. And so now we have 1, 2, 3, 4, 5 roots, and we miss another 2. Lumbar veins and the renal vein and the superannual vein are connected to the branches from splenic, superior mesenteric, and inferior mesenteric, and they are connected here within the mesenterium and mesocolon. Yeah, you may remember how it looks like. You have the gut. The gut has the cover, the peritoneum, and then it's meso. And the meso comes to the posterior wall. At the posterior wall, we have inferior vena cava. Here we have vena porta. And in between are communications. Yeah. So these small communications, which are on the large extent of the whole posterior abdominal wall, they can also be enlarged and form quite a large channel. And we call them Retsu veins. Anatomically, just retroperitoneal Retsu veins. And the last communication which can open is between the umbilical vein and the hepatic veins. We have a fetal shunt which we call Ductus Venosus of Arancius. This Ductus Venosus can be canalized, yeah, recanalized again. And the very last one, how we call this area on liver?
Area nuda.
Perfect, area nuda. So then we have here the diaphragm. And the veins of the capsule of the liver are connected via the area nuda to the veins of diaphragm. And the veins of diaphragm, they drain into azygos and hemiazygos vein. Yeah. They drain via pericardiacophrenic and musculophrenic to internal thoracic, so that's musculophrenic and pericardiacophrenic. And they also drain to lumbar veins. Yeah? As diaphragma is supplied by 6 kind of arteries: superior phrenic, inferior phrenic, posterior intercostal, lumbar, pericardiacophrenic, and musculophrenic. It's also drained by all these veins. Yeah, and this is less clinically relevant as these are just small veins within the diaphragm. But you can see that you need to get the blood via liver. Yeah, using these ways. But if you get it via liver, you have still one problem. And this problem is ammonium. You get the ammonium into CNS, and ammonium is toxic for CNS. Yeah? The task of liver is to change it. Yeah, to change it to glutamine and glutamate. But if it does not work, the ammonium is toxic for the brain, and then this is the problem. So then the patient has to go to dialysis as well. But if you have too enlarged, if you have too heavy ascites and you need to renew the classical way from portal to inferior epigastric, you can perform a TIPS. Yeah, this does not help the hepatic encephalopathy, but it can help the hypertension within the abdominal cavity. TIPS is transjugular intrahepatic portosystemic shunt. What does it mean? It means you go use a catheter and you go transjugular into internal jugular vein, brachiocephalic superior vena cava, right atrium, inferior vena cava, intrahepatic, you get into the liver, you drill a canal between the portal and caval circulation, portosystemic, yeah, systemic means caval, shunt, yeah, as it's a newly performed shunt. So transjugular intrahepatic portosystemic shunt, you just drill it, you can see how it connects here. Yeah, and then there is a relief in portal hypertension, but it does not solve the problem with the ammonium. So now, please, you understand the concept of portal caval anastomosis, and you understand why we insist on knowing them. I hope when you are silent, it means yes. So now caval anastomosis. In case we have thrombosis in either superior or inferior vena cava, you just go back to this I know you are tired but we have to just finish it. Okay, so can we use this for cavo-caval anastomosis? Easily, as you can see that one cavo-caval anastomosis is here. Yeah, superficial epigastric, great saphenous vein, common femoral, external iliac, common iliac. Caudally and cranially, thoracoepigastric, axillary, subclavian, and brachiocephalic. Yeah, so the subcutaneous veins of the abdomen and thorax. Second channel here, rectus abdominis muscle, inferior epigastric, caudally, superior epigastric, cranially. Third channel, we have to draw just here, as we know that the azygos forms the ascending lumbar vein, and hemiazygos as well, yeah, on the other side. So we can use this. I'm sorry, now it's getting a bit full of lines, but this is the second system, yeah, azygos, hemiazygos, and ascending lumbar vein. And the last system we can add easily here as plexus venosus vertebralis externus and internus. Yeah, so all the veins forming plexuses of the vertebral column, and these drain into lumbar veins. These drain into Idiolumbar vein. They drain into lateral sacral vein. They drain cranially into posterior intercostal vein. They drain into vertebral vein. They drain into deep cervical vein. So they drain into all the veins which are close to vertebral column. Yeah. So
Excuse me, sir.
Yeah.
Can I ask a question? I don't know if this is a stupid question, but is the azygos vein continuing down as the ascending lumbar?
Perfect. Yeah.
Thank you.
So this is another, and we call it the Bateson plexus. If you remember, we call it the Bateson plexus. Yeah. And there are no valves, so this serves as the cavo-caval anastomosis as well. If I see this scheme now, it's terrible, I know, but I just wanted to show you how to draw it when you learn it. Yeah. Okay. So when you come back, you can just see here a revision of this. So we have, if we go from ventral to dorsal, superficial epigastric and thoracoepigastric, inferior and superior epigastric within the rectus abdominis, lumbar and ascending lumbar vein, and azygos and hemiazygos along the vertebral column, and inside the vertebral column, venous vertebral plexus of Bateson. And here you just see two figures showing the veins of the subcutaneous tissue of abdomen and thorax. And here, when we have enlarged caput medusae around umbilicus, this is just to show. And I think I have skipped the patient here. Yes, here you can nicely see the enlarged cavo-caval anastomosis. Yeah, here down, these are the superficial epigastric veins. Here, something like caput medusae, and then the veins of the abdomen and thorax. And this is another patient where you can see the enlarged superficial epigastric and inferior epigastric veins. Yeah, so these are enlarged cavo-caval anastomosis. Of course, not every patient looks like this. This is just a nice example to show. And finally, the veins of the lower limb. Yeah, partially, partially repetition, partially something new. I think majority is a repetition for you. Okay, so we have deep system which accompanies arteries. It's doubled, but not as the upper limb to the axillary fossa, but only to popliteal fossa. But the femoral vein can be doubled in 20% of cases. And as they are doubled, they have frequent wells and frequent connections from the medial to the lateral vein. Yeah. Then we have superficial system, of course. And don't forget in the superficial system that we have here a special compartment, saphenous compartment. I will show you the compartment on a figure. And now, I don't know if there will be any phlebologists there among you, but at least you will refer your patients to phlebologists. And there exists a third system on the lateral side of the knee, where we have superficial veins which drain via the gluteal perforating vein deep. Yeah? So these veins are not connected to saphenous veins, but they are superficial. They drain here separately. Yeah? We call it lateral venous system. And it is not easy to dissect it, but in case you have a problem with this perforator, or you have an hereditary syndrome, special hereditary syndromes, you can have enlarged and varicose these veins, which are special. Yeah, so this is just to inform you that exists a third system. It is not necessary to know now, only when you will be phlebologist. Okay, so for the deep veins, there are some different terms from arteries. So what is common femoral vein? Common femoral vein is when we have the deep femoral, profunda femoris, and the femoral. And when they join, we have common femoral. Yeah? And the common femoral changes into external iliac, and it receives the great saphenous. Yeah? So that's the common femoral. Accompanying veins of perforating arteries. Yeah? If you say perforating vein, what it is? Can you give me the answer? What is a perforating vein?
Between the deep and superficial systems.
Perfect, it is. But if you have a vein which is accompanying the perforating artery, you cannot call it perforating veins. Yeah, you need to use this complicated term, accompanying or comitating vein of perforating artery. Yeah, so this is just to understand this term. Okay, how many branches do we have from popliteal vein for the, from popliteal artery for the knee joint? Can you give me the answer? How many branches do we have from popliteal artery to the knee joint? 2 superior, 2 inferior, and 1 middle. So 5. Yeah? But the veins do not follow the arteries. They form a plexus, which we call a genicular venous plexus. Yeah? Okay. How do we call the arteries supplying the gastrocnemius muscles? You remember? We call them sural veins. Yes? Sural arteries, of course, sural arteries. But these sural arteries has different counterparts, gastrocnemial veins and from soleus soleal veins. These veins, after the age of 30, they suffer from sinusoid transformation, and they are often source of thrombosis. Yeah, they are quite enlarged. You can see them very large using ultrasound. So they are clinically very relevant. So please learn the name gastrocnemial veins and soleal veins. And then the last one, as I said, is quite rare, is the sciatic vein. And it can be connected with some hereditary syndromes, and then it can cause such a terrible situations on the lower limb. Yeah. So these are the veins which are different from arteries concerning the deep system. And now superficial system. Okay. So great saphenous vein. Here, I hope you all understand what is subinguinal venous confluence. Yeah? Is it new for someone, or you understand it well? Okay, you understand it? In clinics, it's called cross. Yeah, cross. Please remember this clinical term because it's shorter. So why to say 3 words when you can say 1? I hope you remember we have some tributaries of great saphenous. Then we can have the accessory, anterior, posterior, or even superficial. Then we have these 2 superficial veins, anterior, posterior, femoral circumflex vein. Do not mix it with the medial and lateral. Yeah, they are similar to arteries. They are deep. These are superficial. So the posterior looks like that. The anterior looks like that. Yeah, there's the anterior, there's the posterior circumflex femoral vein, superficial veins. The great saphenous vein runs together with the saphenous nerve, but only in the leg. Yeah, only in the leg, not in the thigh. And here at the end, it possesses 2 valves which border the confluence. So terminal valve at the end and pre-terminal valve at the beginning of the confluence. So in this area. And what we can see here on this figure, this is a transection of the skin and the ultrasound image. You can nicely see the great saphenous vein, and below you see the muscle fascia, in this case fascia lata, and above you see so-called saphenous fascia. And this saphenous fascia, which is also visible here, is just continuation of the Scarpa's fascia of the abdomen and Cole's fascia of perineum. So it's called a membranous layer of the subcutaneous tissue, or a superficial fascia. Yeah? And in lower limbs, it is nicely visible only in the vicinity of the saphenous vein. Okay, let's look here. What is it? Ultrasound, skin, above, muscle, here down, nicely visible lumen of the vein, and muscle fascia below, and this nicely visible saphenous fascia above. Yeah, and this should remind you of an eye of Nefertiti or Cleopatra or any of the Egyptian goddess or pharaohs. Yeah, that's why it's called like that. So if you see this sign, you will never mix this saphenous vein with another vein which can be located more superficially. Okay, what is this? The ultrasound shows you the flow in the vein. And every vein in the lower limb has got a valve. And if the valve closes well, then there are no varices. So this is just the curve which you can see using ultrasound, how the blood flows through the veins. If there's a problem in the valve, yeah, there is this this curve below the line which shows reflux. So this has to be examined to prove the reflux caused by varices. Where does the saphenous vein originates? They originate as the marginal veins. Yeah, we know the medial and lateral marginal vein from this dorsal venous plexus on the dorsum of the foot. And again, as we know, the veins are very variable, so you can see different figures here. Again, you can look at it then at home. So you know what is confluence venosus subingularis, so you know all the tributaries. Superficial epigastric, which we know from cavocaval and portocaval anastomosis. A bit smaller, superficial iliac circumflex vein. External, superficial external pudendal. The deep external pudendal opens directly into common femoral. Yeah, so this is pudenda externa profunda, the deep pudendal external vein. And then, of course, the accessory saphenous vein. So in case you have severe varices, you just cut here the confluence, and this is called crossectomy. That's why I wanted you to know the term cross. Yeah. Questions to this? Okay. Let's go on. Just for topography to understand that the great saphenous vein submerges in the saphenous hiatus in fascia lata. Yeah, nothing new here. And lesser saphenous vein. Yeah, it originates from the lateral marginal vein, runs on the posterior aspect of the thigh, submerges into the fascia, and drains usually into the popliteal vein. Here you can see the continuation cranially, which we call cranial extension. I hope you remember this from the dissection course. Cranial extension. And how the cranial extension terminates. It can terminate in 5 ways, and it is not necessary for you to know it. Yeah, I just tell you how. One is that you see it winds here around and gets into great saphenous vein. Yeah. Or it can drain into the muscle veins, which are here in biceps, semitendinous, membranous muscle. Or it can get deep into profunda femoris. Yeah? Or it can get into the skin veins. Or it can get up to the sciatic vein. So you have 5 possibilities. The most common are these one, great saphenous and deep femoral. Yeah, so it's different in every patient. Again, it can be left to phlebologists, but please remember we have the continuation of the small saphenous vein on the posterior aspect of the thigh, but then it submerges and it fades out somehow. It runs together with the sural nerve, which is very important for neurosurgeons, as sural nerve is harvested for nerve transplants. And again, you can see here the vein and 2 fasciae. So not so nicely, but still the Egyptian eye is visible. Yeah. So that's for the small saphenous vein. And finally, the last topic are perforating veins, the connections between these 2 systems. Yeah. How the blood normally flows. The blood flows when you step on your sole. It is compressed in 2 ways. One is the deep system, of course, the deep system via the plantar veins and posterior tibial. And the second is from the sole to the dorsum into the superficial veins. Yeah. And as we know, on the dorsum, we have the plexus, and then from the plexus, we have 2 saphenous veins, yeah, great and small. So here we have perforators in the foot without valves, yeah, because in every step you just press the blood to the dorsum. The same works in your hand, yeah. Why we have so many veins here and nearly no veins here? Yeah, when I compress it, all the blood comes here to my superficial dorsal venous network and arch. The same here. And then when we have the blood here, it starts to get back into the deep system via the perforators. We have 150 perforators approximately. Yeah. It is not necessary to know all of them. For clinics, it is necessary to know some 40, but I think you should know only 3. And these 3 are here. We call them according to these names. These were the first surgeons who operate them in last century. And we have 3 cockets here in the lower part of the leg. We have 1 void below the knee, and we have 1 dot above the knee. This is what you have to learn for clinics. Of course, they have got their proper names. And if you read the proper name, you start to laugh, as it is really, really long. Yeah? Posterior tibial perforating vein of the leg. So it's easier to say cocket perforator. For the clinics, it is interesting, but not for you to learn, that they have quite precise location, 7, 13, and 18 millimeters distant from the sole. Yeah. So if you find them, you can easily ligate them. And here in the figure, we can see the cockets here. And the cockets are interesting that they do not connect directly the saphenous vein. They connect the accessory great saphenous vein of the leg, yeah, which is not present in every patient. So that's also interesting. The perforating veins can be simple, double, multiple. They can be direct or indirect. They run together with a small artery and a cutaneous nerve. So if you operate on them, you have to be careful not to harm the nerve and not to cause anesthesia or paresthesia. Well, that's it about them. Yeah. So if you want to know more about the perforating veins, I can give you another 3-hour-long lecture about them, which I do for phlebologists, but it's missing in the many anatomical books, and in the Memorix you find it in a special box. Yeah, so please go through them, read it. It is clinically very relevant, but it is not enough time to go through all the anatomy which we have in our human body, unfortunately. So what you can then see here is the ultrasound examination of the perforators. So here you can see a perforator which is very short between the great saphenous and posterior tibial vein, just piercing the fascia. Here is a different perforator. This is a muscle perforator. You can see how it's curved and it goes into the muscle and then into the deep vein. So this is the great saphenous, and here's a muscle. This is an old figure now, we do not use it anymore. It's a venogram, so you can see how the deep veins are connected by a perforator with the superficial system. And here you can see a different colors showing that this indirect perforator has problems. Yeah, so here's a reflux, and this has to be, it's also enlarged and has to be treated. Here you can see some, again, some refluxes and perforators, like here, and here some varices on the perforator. This is just to show you how it can be examined if you want. Yeah, and then you examine it by ultrasound. You make you make a scheme where you will operate, what you have to close, and then what you do with that. Yeah, and why. Of course, it is not nice to look at, but we treat it because the blood flows in the varices slowly. It can cause thrombosis and embolia. But also what we have here as a problem is venous hypertension. And this venous hypertension causes that no more blood can come. So it can cause ischemia and production of venous like ulcer. Yeah. So if you have varix, you can have two problems: thromboticization and embolia, lung embolia, and you can have venous hypertension, and a venous like ulcer can develop. And you cannot treat this ulcer before you remove the varices. How can you remove the varices? So either you totally remove the superficial veins when they are destroyed. Yeah, we call it phlebectomy, as phleps is a vein in Greek, or stripping. Just you remove it, yeah, and you add the grossectomy to that. Of course, this is a large operation, so we prefer the mini-invasive operations. And for that, we can use either mini-invasive surgery, as you can see here, yeah, just small incisions, or we use laser or radiofrequency. That means you put it in, you destroy the vessel, and the vessel contracts and stops the blood flow, or you put inside a sclerotization solution the same way as in esophageal varices. Yeah. So there are many of these. So if you or your parents suffer from these, please go to an ultrasound specialist, and he or she will consider the best way, not just to perform direct surgery, but to apply these lasers or radiofrequency or sclerotization. Yeah. Okay, I think that's all what we have for today. And I exhausted the time, I exhausted you and me, and that's the last lecture which I have here online for you.